In order to build a great team and build a great organization, we have to devote time to training. So for the nurses in our surgical center who do an outstanding job of caring for our patients who are undergoing cataract, premium lens surgery, and various other eye surgical procedures, many of them are new. And so in an effort to kind of give them the big picture of our practice and share with them some of the foundational principles by which we operate our organization, we took one morning to educate them on how our practice operates and what the language is that we speak to communicate in our practice. So if you're a nurse in a surgical center, then this might be of use to you. And if you're a nurse in our surgical center, it will definitely be of use to you. So I hope you enjoy it.
And
thanks for watching.
If you do have questions, we can go over your questions in real time. You don't have to hold them till the end. So it's more of a conversation. So really, I want to give everybody a perspective. What do you see there?
The sky. Hazy. Blurry. Yeah, blurry. Austin. Hazy Austin.
Is that Austin?
Yeah, downtown.
Got it. So that's the, if you're driving up Mopac, that's kind of a view you get. And everybody sees things from a different perspective. If you step back, you see a bigger picture. And that's what I want you guys to see today. Because I think everybody is narrowly focused on their own little world. And that's fine. That's expected. But there is a bigger picture, okay? And I think if you understand the bigger picture, you have a greater sense of purpose, greater sense of meaning. Things are more interesting, okay? So everybody comes to, I want to thank everybody for coming here today and for coming to work every day. You have a choice to come here or not, or go somewhere else. So you have your own little world, and in the ASC you work with the nurses, and you think that's the team, and that's, y'all are the, that is your earth, and you're not sure what's outside of earth. But there's a bigger world, and I want you to understand that. If housekeeping doesn't show up, they're kind of invisible. Don't take them for granted. If they don't show up, things happen, and they become very noticeable very fast. There are people working to keep the air conditioning going, the HVAC, okay, to keep the elevators working. The scrub technicians, if they don't show up, and they seem to show up reliably, which is awesome, then things don't go well. And people do call in. Think life happens. Dogs get sick, people get sick, kids get sick, etc. We have Mary. Mary's not here. And that's oh, there.
Came to learn.
I don't recognize you without a mask. Masks are optional. Okay? All right, I'm an anti-masker. All right. So
Just throw that out there.
it's true.
In case anyone wanted to know.
I've told everybody that in the past. They're the surgical expediters. So that was something that y'all asked for, and Mary's part of that, and the college students are part of that. They're the surgical coordinators. These people here, if they don't do their job, your life becomes more challenging. So recognize that they are a big part of the team. The concierge team, you've probably not met any of them. Gina, Kara, Cheryl. If they don't answer the phone, the patients don't come. Patients don't come, you have no patients in the surgery center. Okay? You have these two people, Megan, Doug. They're integral. Their role is to understand the clinic and the surgery center and to interface between the two of them. You have the ophthalmic technicians. They keep the doctors sane on a daily basis. Because if we had to go through the same discussion, whatever number of times a day it is, in a half day, 15, 20 times in a half day, over a lifetime, it becomes kind of stressful, wears on you, okay? Whereas if I have 4 technicians working with me, they do all the discussion. I don't have to tell the same story every time. They break it up amongst 4 of them instead of the doctor doing it all, which is the way it was done for 15 years, okay? Then it'll drive you crazy. That's why I no longer want to have those conversations. The patient coordinators, they are the front line. You've got your managers, Dan, Sarah, Betty, Megan. You've got Amanda, who's head of insurance, Nicole, who's head of the surgical coordinators. They help make things run. You've got your optometrists who handle the majority of the post-op care for the patients in the surgical center. And you've got your surgeons. All right? So the ASC is a big part of our organization, but it's only a part. So we have 14 nurses here, and we have 7 scrub techs. We have 4 expediters here. Try not to take out your eye.
Because that got kind of close.
We have Mary, and I hope the transition's going well for you, Mary.
It is.
Because yours is a new role. We've never had a person in your capacity. We have Megan. We have Doug, Director of Clinical Operations at DCO. We have 1 practice administrator. We have 50% of the revenue of this organization originates from the ASC. So it's a big part of the organization. So you're a nurse, what do you know? You know a lot about the clinical care, pharmacology, patient care, policies and procedures, and these are all invaluable. You know protocols in and around our surgery center and the operating room, but what do we need you to know in addition to what you just saw? We need you, what we need you to know will make you more valuable, more capable. You will be able to deliver better patient education and better care. And you'll help our organization be what the mission that I've set forth, at least in my lifetime, my career, is the best center for cataract and premium lens surgery in and around Austin. But we need you to understand more about clinical and surgical ophthalmology, because I think that's a hole we need to fill in. Has anybody read our mission statement on the website? Okay.
I don't have it memorized.
For those of you who don't, it's not that complicated, but I've had to go over this with some people in our office. So I'm going to go over it with you guys. So we're now in our 53rd year, and we now have 3 MDs, 3 ODs, about 60 employees, 2 locations. We have our own surgical center and LASIK center. And the mission is, our motto is our vision perfecting yours, and our goal is to create an exceptional team, ophthalmologists, optometrists, nurses, technician, and administrative staff immersed in a culture that is supportive, caring, and focused on helping people experience life to its fullest by enabling our patients to see the best through vision correction surgery. Our why is that when a patient wants the very best care for their eyes and to experience life to its fullest, we've trained, prepared, and have as our ethos providing the best care possible in the world at all levels, front to back, customer service, administrative, billing, medical, and surgical care with a compassionate and caring spirit. We're committed to recruiting, training, and retaining the finest staff possible. Our eye care team is devoted to providing exceptional customer service and medical and surgical eye care. We will continue to evolve and improve in every facet as an organization in the future. So really the challenge is on everybody to continue to evolve and improve, to always be introspective and grow and get better, and don't be stagnant. Yeah, people who embrace these values, this mission, we want to retain and we want to advance and we want to compensate them for. Those who do not, we actually would rather them work somewhere else, okay? Because I don't love mediocrity. I kind of hate it, okay? So that's our mission, to be the best. So that's your challenge, okay? If this is our mission, I'm going to go over some principles that I use on a daily basis. And these principles help me make me better at work and at home. So we have sent a majority of our leadership to a program by a company called Echelon Front. And there's a poster. It's right here. I'm going to put it in the ASC because
I thought we had it in the ASC.
we do not.
We don't.
It's waiting for this. All right. So there are 4 laws of combat, and I'm going to go over them. This stems from some Navy SEALs who were in battle in the Middle East, and they learned that war is life intensified. And whether you're, not into that stuff or whether you're into that stuff, these principles I have found work. They work in everything, okay? So there are 4 laws of combat and 5 mindsets for victory. And I'm just going to go over them. This will probably take 10 minutes. But I think it's important, and if you want to understand how to make yourself succeed and help this organization succeed, these principles are essential. And I find people who don't embrace these things, they're probably not the best fit for our practice, for our organization. So the first one is what happens when things happen. People don't show up. They call in sick. Cover and move. And this is why we want cross-training in the ASC. This is why we want to have sessions like this so we can cover and move. Because let's say I need an instrument in the operating room, and the instrument I asked for, one person doesn't know what it is. The other person needs to be able to say, hey, I know exactly where it is. Go to drawer 2, it's number whatever, instrument number 17. That's the instrument he wants. Or you can page, hey, Trish, you're in OR2, we're in OR3. I need this instrument. And they can cover and move. And this is everybody's personal responsibility to hold themselves accountable, because if one person in the team doesn't succeed or execute excellence, then you have to think about it that it makes the team weaker. And I want everybody to be as strong as possible so you can help your peers. And that applies, again, all these things apply at work and at home. But it's teamwork. So be more knowledgeable. Gain a better understanding of the world around you. Understand other people's roles. We want the nurses to actually understand what goes on in the clinic. So you're a better educator and more capable. If Amy goes on vacation, Lisa needs to cover for her. That kind of thing. Simplify the mission. The mission is we want to be the best. And we have the opportunity to be the best in what we do, which is eye surgery. Oh, go back. Prioritize and execute. So on a daily basis, there's phones ringing. It happens all the time. I'm sitting at my desk. I've got 20 emails. I've got 3 resumes. I've got requests for refills. I've got an email from Amy saying we're out of lidocaine. I've got 2 texts coming up to me saying I've got a patient for you and I've got another patient for you. And then I've got jackhammering below the office because they're building a fence. Okay? So it's just, you have to learn to prioritize and execute. You can't do everything alone. You don't get too excited about it. You just relax. You always take a step back. And then you prioritize. Put the first things first. But what I've learned is I need to rely on others to cover and move for me. So what I've learned is I need to enable and support the people around me to help me out. And that's called Decentralized Command. And that means everybody takes a leadership mindset. Everybody, like 100% of the staff, takes a leadership mindset because we're all trying to help the people around us, and we need to take ownership of that. But the more you know, the more leadership responsibility you should take. Take the initiative, go on the offense. You can't do it alone. You really want to enable and train those around you to help you and make your life better, make their life better, and make the team better. Ownership. This is a great example. I don't know what happened between Kelsey and Doug yesterday, and I don't want to know. But like, what happened is something happened, and then I saw some tips treats on Kelsey's desk, and then I go, what's going on? And there was a note, it was signed Doug, and I go, what's going on? And then Doug walks in the room, and he sheepishly says something along the lines of, I'm sorry. So all I know is that was good because he was taking ownership of whatever the heck he did. And that's good. You never should blame others. Let's say in the instance of what I mentioned before, let's say somebody doesn't know something in the operating room. I don't really want to blame that person. It's really my job to educate that person because they didn't know. But as long as I have that mentality and everybody has that mentality, then there's less blaming. There's less finger pointing. It's like, oh, okay, it's my fault. I need to support you more. So that's kind of the reason why we're here. If I see things that are not quite right, it's my fault because I need to explain to you the mission and the why and go over all these things with you and have Q&A. So if there's problems, I'm going to take ownership of it. We just don't want to sit back. I mean, for better or worse, I won't point fingers, but yeah, you just want to. We were having a little private discussion the other day, and the thing was, hey Shannon, the staff thinks that you are money driven, and I go, I'm not really money driven, but I do like to measure things. I count cataract cases and whatnot. The whole reason is if I'm going to do something, I want to be able to measure the result. Otherwise, you don't know if you're getting better or worse. If you don't track it, you can't hold anything accountable. So we want to. So I'm driven to make things better, grow. I mean, I want to do more volume. What does that do? Surgical volume. Well, it helps to purchase equipment, to pay your salaries, to give you raises, to give incentive bonuses, to give whatever, support your livelihood. I think in your life, reflect on things and are you getting the most out of every day? I would challenge you to do that. Innovate and adapt. Let's say you've been here 5 years. You shouldn't be doing the same quality of work that you're doing a year in. If you've been here 2 years, you should be a much better player than you were at 1 year. And the only way you do that is to take the initiative. You go on the offense, you see the initiative, you make things happen, you learn. You take an active role in learning. So things like, let's say you have downtime. Maybe you could learn a new skill in the office rather than get on your phone. Innovate and adapt. Educate yourself. Humility. I think nobody is better than anybody else. So always, I found that in life, I really admire people who are selfless. It's like, I just watched Top Gun, and the Top Gun Maverick. Okay, the times where I got choked up and I actually wanted to cry, it's because there are some scenes in that movie where somebody puts themselves second, and they sacrifice them. They endanger themselves to help somebody else, and it's a form of humility. I think it's so. Just in your role as a leader, just be helpful. Check your ego. Nobody's better than anybody else. We're all human, and just stay focused, stay disciplined in all aspects of your life. But at work, show up on time, be reliable, be supportive. If you're given a task, get it done. In your personal life, watch your diet, exercise, be responsible, be on time. Same thing. So how do we achieve our mission? We need ideas, people, resources, education, training. And if we have these things, will we achieve the mission of being the best? What do you think? I think that's wrong. And I came to this realization. Okay? Because you can have ideas, people, and resources, education and training, but you also have to have the ability, the will, the curiosity, and the drive to make all these things happen. Without that, going on the offense, default aggressive, let's pull this thing out. It's all the same principles. Unless you have these things, you really don't, you'll achieve far less. You'll never be great at anything. So like when I'm working out in the morning with a guy who helps me exercise, one of the things he uses to kind of incentivize us is, you want to be great? And it's a good thing. It's kind of challenging, okay? But you won't unless you have that drive, that curiosity. So open your mind. In our practice, who do you think comes first? Patients, the customer, or the staff?
Customer, the staff.
I feel like here are the staff and then the patients. Because staff happiness equals patient happiness.
You got it. Winner.
10 points.
Yeah, so the way I grew up doing things, I was taught the customer comes first.
Yeah.
The patient comes first. And that led to like a less than ideal work culture for a long time. Okay? All right? So we learned that the staff comes first. It's almost like, I use a lot of sports analogies, like if I'm Jerry Jones, owner of the Cowboys, who comes first, the fans or the players, and the organizational management? It's really, if you don't take care of your team, team's not going to produce a product, fans won't show up. And it's proven to work because, the happy staff has proven to take better care of our patients, and we've done better over time. So since the staff comes first, we need you to take ownership of everything around you. And what does that mean? There should be no excuses when it comes to technology. Don't lean on Doug. Doug, fix this. Okay? If he comes up to fix something, say, Doug, let me watch what you're doing. Let me learn that.
I would say on second thought, I will be more open to just having you observe and try to be more teaching.
I was about to say, Doug's a doer.
But
The printer has his password. We don't even
okay,
have it.
Well,
but
that's
we
a
have to
different
get him
thing.
to come up.
okay, but
different thing.
other things. But
That's a different thing.
if you're taking ownership of everything around you and you have a computer problem, then you should learn how to solve that problem next time. That's decentralized command. He shouldn't be the easy button.
If it's something you can
Okay.
do, I will teach you. But if it's
Yeah.
something that I have to do, then obviously I have to do it.
Scanner.
Yeah, the password thing. I gotta look at that later.
Okay.
Problem for today's day.
So inventory management, I appreciate, how Amy goes through things. Megan goes through things when they're tracking statements. I want you to track it and hold the vendors accountable as if you're spending your own money. Okay, it is appreciated. If I were in your situation and I were reviewing your bills and your statements, you would want me to do the same for you. Take ownership of that process. Knowledge. Have a curiosity to learn more, do more, be better, more capable to help your team, your patients, and ultimately yourself, because it makes your life more fulfilling. Take care of your surroundings. So when we opened the building, I said, I want everything neat, clean, and organized. I don't want clutter. Take care of your work environment like you would take care of your own home. Take ownership of your role. Learn and master your role. Become so proficient at it, you can train the next person and improve your coworkers' understanding of your role. Then you can learn another role, master the next role, and then the next, and then think at a higher level to help the team from an administrative perspective, and then help management from an organizational perspective. This is what growing and making things more interesting looks like. Our goal is to be the best, and we just need highly motivated people to achieve that. So how many cataract surgeries are performed annually in the United States? Anybody have an idea? Any guesses?
Like I'm going to say 2
The most
million.
common procedure.
I want to say it is. I don't know. Is it still? I think it's still the most common.
5 million.
10 million.
Okay. So it used to be the most common procedure in the United States, but it has been supplanted by the intravitreal injection
that
used
makes sense.
to treat retinal disease.
Yeah, all the diabetes.
Yeah, or macular degeneration. So patients with macular degeneration or recurrent macular swelling, they'll need an injection every 3 to 4 months
I guess that
for the rest of their lives.
I guess that counts as a surgery, huh?
It does, yeah. So there's, in 2021, this is from a very official source called Market Scope. So it's 4.6 million cataracts done in the United States. What's the population of Austin?
It's over a million now.
Okay. Wikipedia says over 1 million.
Nice.
Yeah. So we're the 10th largest city in the United States, only the 4th in Texas. So we're still behind San Antonio. How many ophthalmologists are there in and around Austin, Texas? Any idea?
Are we counting retina too? I'm going to say 50.
50 total.
Less than
Are you counting right now?
Yeah.
If we're counting retina, I'm going to say like 50.
30.
I guess 70.
60, 70.
Okay. So according to the Travis County Medical Society, there's about 125.
Ah, crap.
Well, I was thinking about Austin right now alone has like 12.
Okay. So there are probably 30 ophthalmologists of these 125 that do premium cataract surgery, and probably half of those, this is my instinct, do premium lens replacement. So cataract surgery is a pretty big deal, and it's really the driver of our whole organization. So over time, we're always looking to make changes to grow the volume. And between, let me see if this worked, yes. So between 2021 and 2022, if we're looking at January to May, that window of time, we've grown our volume 35%. For premium cataract surgery, between January, this is January to May, yeah. January to May, 2021 to 2022, we've grown that 38%. Our total cataract surgery volume has grown over time. When we originally got the LensX laser for laser cataract surgery, that's when we really got kind of ambitious. We bought an expensive piece of equipment back then, and we wanted to promote it, so we started marketing, and we wanted to grow the volume. We were doing less than 1,000 cataract surgeries a year in 2011. And last year there was a significant increase in our total volume because we made some changes. And the changes largely were from just opening our mind. The story goes, I was talking to a friend of mine who has a practice in Plano, Texas. And it was like February of 2021, and we're talking about like COVID stuff and how you run the business. And he goes, "Yeah, I'm pretty busy." He says, "Shannon, this is when in 2019, 2020, we were doing 2,000 cataracts a year with 3 surgeons." And he goes, "Shannon, yeah, I'm getting busy," and he's one ophthalmologist, not 3. He goes, I'm doing about 2,600 cataracts a year. I go, "Wait a minute, how do you do that?" He goes, "Well, I operate 2 half days a week." I go, "Wait, what?" "We have 3 surgeons and we're operating how many half days a week?" I go, "Hey, do you mind if I come up and watch you?" And so we go up and watch them. And I'll show you some clips of what we saw, but we've implemented most of the changes. Most, and we're not going to implement all of them, but most of the changes, and I think that has made a huge impact on our ability to generate more surgery. And that's the reason why a lot of you are actually here today, because with more patients, more surgery, we need more staff. So the premium surgical volume went up significantly last year. We went up 71%, which is everything. And so this year, Megan and Doug were at the meeting, I think, where I just kind of did an analysis. I kind of tracked things, and I go, well, January is always the slowest surgical month of the year. And the second half of the year is always the busiest time of the year from a surgical volume standpoint. So I said between 2016 and 2021, there were 2 years where there was a 30 and 36% increase in the annual monthly volume compared with January. So if you look at January and you do 100 cases, there were 2 years where the average was 130 or 136 cases per month, even though January is only 100. Okay? So the average monthly volume for cataract surgery in 2021, last year, was 63% higher than the January 21 volume. So if like in the years from 2016 to 2019, if we're doing 100 in January and we did like 125 on average every month thereafter, well, 2021 we did 100, but then we did 163 a month thereafter. So 2021 was busier because we made a lot of changes. We opened our mind. So in January 2022, I said, well, what did we do? Well, we did 246 cases. And the number of cases we did last year was 2,931. So I said, well, let me just do some projections based on looking at how January indicates what we'll do for the rest of the year. So I said, well, there's a worst case scenario. if we did 2,900, whatever, let's say 3,000 cataracts in 2021, then worst case scenario, we're going to do 3,601 this year. That assumes that we'll do 22% more than January 2022 on average per month. So it's about 300 cataracts monthly. The base case would be we do almost 4,000. That assumes we do 33% more than our January month, monthly for the rest of the year. And then there's a bull case that says we do 40% more average monthly for the rest of the year than we did for January 2022. So I'll tell you we're on course to probably go our base case right now, but we haven't yet hit, or we're just starting. No, we haven't even hit the second half of the year.
Yeah, no, end of June would be the.
So it's hard to tell. So we're like, we run negative splits if you're into running. We run the second half faster than the first half of the year. So let's go over basic concepts that I want you to know. And a lot of this, these are terms I want you to know. So who doesn't understand nearsightedness? Let's explain it to you. Anybody?
I don't understand what nearsightedness is. You can explain it to me.
Thank you, Doug. So most people tend to be nearsighted if they're younger and they need glasses. So probably Abby's nearsighted.
I am.
So that means you can see close pretty well, but you can't see far away. And I think most people get that. And then there's,
Also known as myopia.
it's also known as myopia. Hyperopia, also known as farsightedness. It's one of the most misused terms in the medical world because the presbyopic patients think they're farsighted. It's like you'll never get the world to pronounce the word astigmatism correctly. It's just, or call an ophthalmologist, not call an ophthalmologist an optometrist. It's never going to happen. All right. So farsightedness means that you see best far away, but it's actually not great, or it's very strained, and your vision gets worse and worse the closer it moves. So there's low degrees of farsightedness, like if we're looking at numbers. So like a farsighted prescription, does it start with a minus or a plus?
Plus.
Thank you. So thank you. So if you're a +2, it depends. How are you going to see? It depends on your age. If you're 25, you see great. You don't even know you don't need glasses. You see great, because the younger we are, the more capable we are at focusing in and out. But a +2 at age 38, they're going to be wearing reading glasses. A +2 at age 45, they're going to be wearing. They're the people who come in and they say, I don't need glasses. I drive without glasses. And they'll get some +2 glasses and they'll say, I use these for reading. And they think they're normal. These are the ones that we love to come in as a consultation, because they don't realize that they're out of focus, far, mid, and near. And though we don't have perfect technology, we can get them a lot better vision. The +2 at 60 or 50 is worse than the +2 at 60 is like easy to satisfy. Farsightedness. So how does that differ from presbyopia? Presbyopia means, well, let's see. So farsightedness, farsighted or hyperopic people, they're always out of focus. They have to use their lens to refocus. And so if you're a younger farsighted person, you're using reserve capacity to see far, and you only have a finite amount of focusing power, and the older you get, the less focusing power you have, and you run out. And so you go into glasses, even as a younger person. So like there's a guy we operated on yesterday, 35-year-old. Yeah. So he comes in, he's a plus 650, and he's 35, and I go, you know, you're young for lens surgery, but we can go over it later. But basically, if we do LASIK for those people, you take a cornea. So here's the cornea. You take their cornea and you make it really steep. Okay? And they will see. But corneas don't like to stay steep. They will flatten with time. He'll, if he's 35, if I did LASIK on him, he's a plus 6. I could make him 0 prescription. 40. By the time he's 40, he'll be a plus 3.5. By the time he's 43, he'll be a plus 5.
Totally.
Yeah. And so, I mean, before we had lens surgery, I treated these patients with LASIK. And they all come back saying, and it's kind of like, sorry, dude. Because they come back and they're the same as they were before they had LASIK. On the other hand, nearsighted people with LASIK, you take that cornea and you flatten it. And corneas love to stay flat. They will stay flat. So there are people in this room who've had LASIK, and if you were nearsighted, you'll just be stable. So that's that. So this 35-year-old, because he's so farsighted, we couldn't do LASIK, so we put lens implants in him. And I warned him, I said, you know, these lens implants are not really used that often in people your age, but he's highly motivated. There's no other option. So I think he's okay.
Later.
Yeah.
Will it, and again, I know you replaced the lens, but because he got it in such an early age, what is when he gets 60?
So the way I describe it is I'll say, hey, you know, you're going to see like a normal-sighted 40 to 42-year-old. You're 35.
Right.
It's not that appealing, but if I take, I'll use me. If you took somebody like me, age 54, and said, I'd make you see like a 40 to 42-year-old, I'll make your physiology 40 to 42, I'd go, dude, I'm in. Sign me up. Okay? But he has no other options. He hates his contacts, he hates his glasses, so he's willing to tolerate that. But he'll stay like a normal 40 to 42-year-old the rest of his life.
Okay.
Yeah, so patients, so your lens in your eye changes. So when you're born, it's thin and clear. And it keeps growing more cells as we age. It eventually gets bigger, 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 wider, 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 taller, 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 cloudier, cloudier, cloudier. So it's a dynamic structure. And that's why you need different glasses between the age of 21 to whenever. But when we remove that lens, we replace it with a static implant, and so the vision becomes much more stable. They don't need glasses as often. Their prescriptions don't change very often. They're really stable.
So the anatomy of the eye then, does it continue its original process, which would be to make more cells on it, and it doesn't integrate it as a
No.
as match the
No, because we remove the cells that would multiply. Some cells remain, and they grow on the capsule.
Right. Okay.
And if they cloud the capsule, that's when we do the YAG. But for the most part, it's pretty quiescent.
Thank you.
Yeah. Cataracts, glaucoma, eye anatomy. Let's go over some of these things with technology. Let's do Rendia. By the way, this is available to everybody. If y'all need to use it for patient education.
It's on our
Yeah.
It also helped me when I first started. I used to go
It's just,
That's the password?
that's the password.
Yeah. So nearsightedness is basically when the eyeball is longer than desired. So let's go back here. This is the normal eye, and the normal eye has a distance from the front to the back, and we'll cover this in more detail. So this distance, on average, in an adult eye, because that's what we deal with most of the time, is about 23 millimeters. And we measure this on our lens star. And the nearsighted people, why are they nearsighted? Well, what is nearsightedness? It means that they're, let me go back. The picture that should come into focus right here, it comes into focus in front of that location. So the image is focused in front of the retina. And it's two reasons. Either the eyeball is too long, or their cornea is steeper than average, and that steepness causes the image to focus in front of the retina. So those patients can see close, but they can't see far. So when we're doing surgery to correct nearsightedness, we're pushing that focal point, as you saw it in that graphic that we'll replay. It pushes the focal point where we want it, and then they can see better far away. Glasses do the same thing. This should show LASIK surgery reshapes their cornea, and it pushes the image to where it should be, and lens implants do the same thing. Farsightedness, similar story. So the eyeball is too short. So instead of the eyeball being 23 millimeters, it's probably like 22 or less. And you'll see these on the lens stars. Or their cornea is actually flatter than normal. Okay? Those are the two most common causes of farsightedness. So the treatments, well, farsighted people, they see okay far, but not great, and they see blurrier as things come closer. So when we're treating them, we're moving the image inside the eye as if the eye were a normal size, the eye were longer. Okay? Presbyopia, I hope you guys get it, but I'll go over it one more time this way. I think of it as the lens is losing its elasticity. So like, well, the lens is here, it's very flexible when we're children, and invariably with 100% certainty, if you live long enough, you'll lose elasticity to that lens. You'll lose your ability to zoom in and out. So that's just a stiffening lens. It can't pull the image and maintain its focus on the retina as we age, and that's when people need reading glasses.
Is that always the cause of the lens or the zonules?
It's always the lens loses its elasticity.
The lens, okay.
It's almost like my spine is not as mobile as it once was when I was younger. It's just one of those things. What else did I have? Astigmatism. We go over this quite often. In fact, we're influencing astigmatism 100% of the time when we do cataract surgery. So the most simplistic way to think of astigmatism is the cornea at the front of the eye should be round, like a tennis ball or a ping pong ball. Another way of thinking about it is like if you take a plate. The curve in every meridian should be the same. That's a sphere. That's ideal. That's ideal optics. Astigmatism occurs when you get a steep and a flat curve. So as a visual aid, so this is perfect no matter which way you go. It's the same curve. This is an example of astigmatism. You will have two different axes One is steep, one is flat. Okay? So let's say this is my astigmatism. My eye is like this. If I'm steeper here, this is the 180 axis, this is the 90 axis. You make an incision, the incision always causes that axis to flatten a little bit. The bigger the incision, the more flattening. The deeper the incision, the more flattening. The closer toward the middle, the visual axis, the more flattening. So where we place our incisions matters. So let's say this is my astigmatism. If you make my incision here, it will flatten this already flat meridian. It'll make my astigmatism worse. Okay? So here's that picture of astigmatism. The way we tell patients after surgery is, when I use this contextually, is I say, that's a sphere, that's astigmatism. Astigmatism is causing the image to blur out. It creates multiple images of focus. So our goal is to make your cornea more round, and I'll tell them typically we'll make an incision in your cornea, and that will cause your cornea to, let me see if this is my correct thing. No, let's go back. I stopped it. That incision will make your cornea, oh, I reversed it is what I do. I use this on my iPad, it's a little different. It'll make your cornea more round, and you'll see better. So we can also do this with the excimer laser with LASIK. But I think those of you who are in the operating room, you are aware that we take these things into consideration.
I have a quick question.
Yep.
Do you do a scleral tunnel to reduce the astigmatic impact of the incision?
Yes, I'll show you a image. Let's go there now. The phoropter. We'll get there.
Got it.
This is how we measure people's prescriptions. We have all these gadgets and gizmos. This thing's been around forever. And this is really the workhorse instrument that we use to measure people. So there's this, just put this image in your mind. This is the patient's left eye, this is the patient's right eye, and it's like a what's that thing? A protractor. Do they still use those?
Yeah. Engineers do.
Okay, fine. That was in my school supply list when I was growing up. So 0, 45, 90, 135, 180. You'll see this on our axis marker that we use in surgery. It's what we envision. I don't know what the other doctors do, but when I walk up to the patient, I go left eye, and I go, I'll mumble like a diopter at 30. I'm envisioning this picture and where I'm going to place my incision. In the operating room, y'all have made this, which is basically the phoropter. Okay? So, yeah, we're going to go over, let me think here. Yeah, this is, we'll cover your question here, Jake. All right. So what is keratometry? This is nurses. Anybody?
Measurement of the corneal radius of curvature.
Okay. Right. All right. So what is Careto refractive surgery?
Where the incisions are made to flatten out the cornea?
It's surgery, it's refractive surgery, which is any surgery that influences the focusing property of the cornea. Okay? That can be a cataract incision, it can be LASIK surgery, it can be an astigmatic incision, or a limbal relaxing incision. Okay?
Can I ask you a question I want to forget to ask?
Yeah.
Maybe you'll answer it today, but patients that are myopic and they have LASIK, right? So we're making their cornea flat. Why do some people have to get retreated? Is it because of the astigmatism that comes back? the ones that need retreatment?
Okay, so the LensStar device, it is super accurate, but the calculations that we use from that machine to plan the refractive target in patients that have had LASIK surgery or RK surgery, those calculations are less accurate.
Is that why you use that True K or?
We still use it, but it's just there's no formula that goes, this is with 95% or greater certainty going to give that patient their in focus. So there's a higher retreatment in LASIK patients. So of all you people in this room who had LASIK, when you have your lens surgery, if technology to improve, there's a higher chance that we're going to have a refractive miss. We're going to have to retreat them. I don't think y'all see the retreatments that often. They're mainly done with Careto refractive surgery in our LASIK suite downstairs.
Well, I was specifically talking about your LASIK patients that come in
like
and
an
they
original
get
LASIK and a
LASIK in
repeat
20s and maybe come back and get a retreatment. Those people.
Oh, okay. So let's use you as an example. So you had LASIK a decade ago, and your lens inside your eye is, remember, it starts thin and clear, and it's getting bigger, bigger, and a little cloudier. That's changing your focus. So, yeah.
So it's not the cornea is changing.
The cornea,
Cornea doesn't change that much. It changes a trivial amount compared to the lens.
Okay. So our patients that you're doing an AK in the operating room, now those patients aren't going to have any issues with that in the future, the fact that we're doing an AK versus a toric lens?
So astigmatism can be treated at the cornea or at the lens. When they have smaller degrees of astigmatism, so a toric lens starts at T3. Why isn't there a T1 or T2? Okay.
Well, there's a T2, but not in the United States.
Okay.
So.
Those are smaller degrees of astigmatism. So it's almost like a car that goes 0 or 30 and above. But if you want to go 1 to 29, there's no setting for that. So when patients, let's say I only use toric lenses and I don't do astigmatic surgery on the cornea,
Sounds accurate.
there's a gap there that I don't think like that. So I think if they have smaller amounts of astigmatism, I'll treat their cornea.
Okay.
If they have larger amount, okay, there's little nuances, and I'll go over with you when I address Jake's question too about where I place the incision. But this is a trivial thing, is I think rotating a toric lens is kind of a time-consuming maneuver, and it takes more time to do that than an AK. So if I have a choice, I'll do an AK or an LRI. And I'll tell you the difference between AK and LRI in just a second.
What about like the DIU 150? Does that, I mean, I know it's
DIU
Alcon
150.
versus.
DIU 150, that's a iHance?
I'm right, but it's a toric.
Okay, fine. Yeah, what about that?
But that's narrowing that gap. I mean, granted, I know it's Johnson & Johnson versus Alcon, but that's that.
I think the DIU 150 is equivalent to the CCWTT3.
Oh, okay.
It's comparable.
Like 1 and under, or 125 and under, he's going to use a corneal incision because there's no lens that fits that criteria.
And I know a lot of doctors don't do corneal incisions, but I'm like, what? Well, you're inducing astigmatism somewhere else because you're only using a
one size fits all.
Yeah, it's not. It doesn't have that fine tune. It's like a macro focus without a fine focus.
I guess the next corollary question to that would be, what amount of astigmatism can a patient have before they notice it?
Okay, we'll go over some of those. I've got examples.
Okay, great.
All right, so then next question. What is the name of the set of measurements that the doctors look at during cataract surgery?
There's like a million things.
There's a lot of measurements.
Well,
The LensStar?
LensStar. That's what I was looking for. Can you name 3 lens calculation formulas that the doctors use from the LensStar for calculating the correct IOL power in normal eyes, i.e. eyes that have never had prior keratoconus refractive surgery. Okay, good. Can you name 2 formulas that the doctors use from the lens star for calculating the correct IOL power in eyes that have had prior keratoconus refractive surgery?
Barrett,
False.
True K.
True K, yes. And the Holiday 2, but I'll show you, you always have to make sure that
There's a
there's
thing.
an extra
And
thing
circle
noted.
by yes.
Okay? So, how does the location, this is where we get to Jake's question, how does the location of the primary incision affect the surgical visual outcome for the patient during cataract or premium lens replacement surgery? So again, this plate analogy. So here, it's steeper along this axis, it's flatter here. So which way should I bend my plate to make that happen? Yes, like this, okay? This and this are parallel, all right? So how much flattening do I get, okay? When I make my incision more peripheral, I get less flattening. When I make it more closer to the middle of the cornea, also known as the visual axis, it has more impact. So I get like, does anybody know the diameter of this blade that we use to make our primary incision?
2.8 millimeters.
2.8 millimeters. There are blades that are like bigger. There are blades that are smaller. Some patients, but we're comfortable with what we do. And that's a whole nother, you get to spend 2 hours on incision size for cataract surgery. But suffice to say, if your incision's too small, you can crimp the sleeve of the phaco needle, which will decrease flow. And as that needle is vibrating, it gets hot. And you can get burns to your cornea, which induce massive amounts of astigmatism. So if the cornea ever turns chalky white while they're doing phaco, you're just got to burn, and that's a long story, okay?
Oh, man.
So like you'll see for the scrub techs in the operating room, when I use clear visc and I do my capsular excess and then I go in to do phaco and I start sculpting, if I don't see the clear visc coming out, I go to higher vacuum. And the reason is there's stasis of flow, and I can tell, and I want to increase the vacuum. I want to pull out that clear visc a little bit to give fluid room to move, and then I'll get flow through my sleeve and I won't get the burn. But if I just start hammering away, sculpting, it's bad stuff. Okay, so if I make my incision, the cornea is wider than it is tall. It's kind of oval, a little bit. So this is maybe like 11.5 millimeters. This is like 12 millimeters. On average, these are average. Everybody has variation. It's like the shape of your head. All right? But if I make my incision, in the cornea, up top, and it's age-based, but let's say on an average patient who's 55, 65, I'll get about a diopter flattening. If I move that incision below the conjunctiva, this is where I'd have to do a conjunctival peritomy. I'll ask the scrub tech, I need 0.12 in Westcott's to kind of peel back the conjunctiva. I'll get about 3/4 of flattening, of diopter flattening. So that means this would become 3/4. This would become 45.25. There's an equal and opposite shift here. This would become 40, well actually, the net difference between these, so it's 3 diopters, would change to about 2.2 diopters of difference between the two. If I move it even further back, I get about a half a diopter flattening. If I move it even further back, I get about a 1/4 of a diopter flattening. So when I'm sitting there figuring out where to sit, I'm also thinking how deep set is their eye, how bad are their lashes, etc. Because I'm thinking about how to get their astigmatism to be almost zero. And I say almost zero thinking because there's a topic that we're not going to discuss today. It's called posterior corneal astigmatism. All right, so there it is. Okay, good. Have you guys looked at this chart? We hand it to all the patients. So I think it's important to always understand kind of what the patient experience is from their perspective. Because it's easy to just kind of get lost in the clinical part of it. So if a patient chooses a basic lens, they pay their insurance deductible and copayment. If they choose an astigmatism correcting lens, they pay out of pocket because insurance doesn't cover correction of astigmatism. Does anybody know what the patient is charged? I'm going to give you two scenarios. If this is the cost per eye for the patient, they want to see to drive without glasses. That's how I present it. You have good driving vision, TV vision without glasses, but you need glasses for mid and near. Any idea how much they will pay out of pocket for that in our practice?
Not visually significant.
Yeah, it's not visually significant. So, and this is the visually significant patient. It's upgrade. They have insurance contributing. So here, if they're cash pay, completely elective, private pay out of pocket. Any idea how much they pay?
60.
Okay. So I want you to realize that what the price of admission into the hotel is when you see these patients. They pay $5,700. Okay, so if they go to other practices, this fee is composed of not, so it includes.
I'm pretty sure it's 54. It's 54 for that one.
No, it's 57.
Did it go up like? We just never do that one, so it's just like not.
Okay, so this covers the surgery, surgeon's fee, the facility fee, anesthesia, any retreatments for a year, any capsulotomy within a year. If they have insurance, it's $3,100. Okay. Now, this is our most common. How much do they pay out of pocket for a premium lens replacement? Any idea?
$6,200.
Correct. It's $6,400 for all the premium lenses. Vivity is considered premium. How much do they pay out of pocket if they have like Medicare and insurance? Yeah, it's $4,500. Okay. So when they have premium versus astigmatism, be aware of why they may be very picky. Okay? The more you pay, the more picky you get. So this is probably going to be a lens that we will be using this year. It's called the IC8. It will be a premium lens. It's based on a pinhole design. So Vuity drops, you ever heard of those?
Yeah.
It's drops that constrict your pupil to make it smaller. This makes it, I forgot the diameter, it's like 1.6 millimeters in diameter, something like that. But if you look through a pinhole, it gives you real good focus, far, mid, and near. We'll see where this comes, what role this fills. I'll tell you where they're going to definitely go after is patients with like radial keratotomy, who have uneven corneas, or keratoconus patients who have uneven corneas. So the patients who currently receive a lens that we've chosen not to use, called the light adjustable lens. That's for people who want really clean, sharp vision without artifacts, etc. And so they adjust the implant inside the eye using some proprietary technology. This will probably make the light adjustable lens even less attractive.
What makes this lens?
It's called, I forgot. Acufocus. Okay. Beg your pardon?
They're only mono.
This is a monofocal, but it has a depth of focus.
Yeah, that's why it's good for arcade.
Does it make your vision like dimmer?
Arcade
It might.
don't really get along.
That's what, yeah. That's a
So
good
this is a
question.
good option.
But also might have less halo.
Good for arcade. Okay.
So there's still no perfect lens.
Yeah,
Like theoretically, for like your 80-year-old cataracts, they probably already
Yes,
see
right. You can
dim,
imagine
right?
if
So
you've got cuts in your
the dimming
cornea.
relative to this lens may be.
But you
not
probably do you think that this would be better than Panoptics for like a premium lens?
We'll find
We'll
out.
tell.
But what's your predictions?
I don't know. We'll use it. We'll add. So on this chart, what's going to happen is I'm going to take this out and I'm going to put that lens right there in the chart.
And so you would explain it as a depth of focus with no halo.
It'll be kind of like a hybrid.
Potential dimming.
It'll be a hybrid of
Dimming and
this.
peripheral.
It'll be. I don't know all the strengths and weaknesses of it, so I can't.
Do you know when it's coming out?
I'm told this year. Yeah. So they're just like we were evaluated by the Texas Department of State Health Services, and they said, here's your plan of corrective action before we review you again. And we're going to give you some time, and then we're going to come back and review you before we give you your official license. Like AccuFocus is, I think, the name of the company that makes that IC8, and they got reviewed, and they've been given a plan of corrective action, and once they meet that, then they'll probably get their final stamp of approval to launch the lens. Okay, so viscoelastics, let's talk a little bit about them. So we use Helon GV, we have used Endocote, we have Helon 5, we have Amvis Plus, is that what they use? What are they using? Amvisc. Okay, Bausch and Lomb.
We have both, yeah.
You have both?
Yes.
What's the wait, what are they using? What are they using these two?
Well, they use
All
Amvis.
the time.
In lieu
You
of
have
Nuvis.
Nuvis.
Okay, and what are they using this for?
That's heavier. I mean,
I don't know. I don't know
I think we
that
just got a trial of it, right? So you just have it.
Oh, we don't have much of this, right?
No.
Okay, got it. And we use OcuCoat.
We were using Amvis Plus in lieu of GV when GV was off the market
Oh,
at that time.
maybe that's why. Okay,
That's
got
why we
it.
had it.
So, there's two types. There's a cohesive. Think about it as if it sticks together, and it tends to be heavier, and it's easy to remove. It comes out like, okay, like pinching the zip. It comes out. All right. The dispersive kind of spreads out, and it kind of sticks to the surrounding tissues, and it tends to not come out quite as easily. So I use this. It's dispersive, right? It's dispersive. I think it's dispersive. Dispersive. I like it because it's 1 ml, right?
Yep.
Yes.
Somewhere in here, maybe.
It's very
I just know.
1 ml.
I just know that.
1 ml. I use it because I can coat the cornea with it. Helps me to see better. I usually have to use one tube, and I can use it for the whole case. I used to use Endocote, now I use Clear Visc, which is, next slide, Clear Visc, for when I needed something to stay in the eye. So Clear Visc, it's dispersive, stays in the eye longer, it's heavier. Clear Visc and Endocote, they're very similar. 800 Daltons versus 80,000 Daltons, heavier. Pushes things back. So like when I use a bent needle for my cystotome and I hook it up to the OcuCoat, it's because the OcuCoat, because it's not very heavy, it kind of comes out of the eye. And I have to push a little more. If I use the Utrata forceps with OcuCoat, the forceps kind of open up the primary incision and the OcuCoat comes out of the eye and the lens comes forward. It makes making the capsular access more challenging. So I generally don't do it. But if I use Endocote or Clear Visc at the beginning of the case, I can use the Utrata because that stuff stays in the eye. And so the lens doesn't come up and come toward me, and it's just easier. Helon GV, I use it to expand the capsular bag.
Can you explain why you use Helon GV in the oh poop moments. Like if you know something's happening, it's almost always you're asking for Helon GV.
Okay, let's go over a case.
Bad breaks, AC rent.
Let's go over a case. So one of the questions that lovely Dawn asked me was,
Number 2.
would you be able to walk us through a video of posterior capsular break and point out what the nurse should be looking for in real time so that the nurse can quickly recognize a PC break to anticipate the surgeon's needs? Okay, I'm going to tell you a couple things. It's not your job to recognize the break. But if you can, it's bonus points. It's definitely the surgeon's job to recognize the break. So let's show you what. So since this was not planned, but it was yesterday.
It never is.
So yesterday was a little, so you full disclosure, yesterday was a day where I go, let's go a little faster. And this one slowed me down a little bit. Yeah, okay. So this is a basic case. Basic case. Who was with me?
It was Jake.
Jake, okay. So this is illustrative of a normal case. That's our sapphire.
1 millimeter.
And we've numbed the eye already. We've already dropped. This is 1% lidocaine. Thank you, Lisa. You said you better use it. Patients are complaining. Okay, so I'm using. I'm sure yeah, it's fine. I need to.
Ocucoat.
Yeah, Ocucoat. So that coats the cornea. So it makes it easier. So now there's my 2.8 millimeter diamond. This patient probably has about a diopter of astigmatism at that axis.
I think this was a basic case. Right?
It's a basic case. So here's my little, it's like a 25 gauge Pierce irrigating cystotome. And I pushed some viscoelastic in the eye because I want that lens pushed back. I don't want it to vault forward. So some people place marks on the cornea to judge the diameter of their capsular axis. Some people have a instrument that they place in the eye to measure it. I just look at it.
What's the ideal millimeter?
You want it to be smaller than the optic. The optic is about 6 millimeters in diameter, so it's like 4.5 to 5. And I think we're pretty much there like 100% of the time. So then,
Consistently pushing more viscoelastic in.
just a little bit, because I need to conserve it, because I need it for the end, right? I don't want to run out. So there's my hydrodissection with my chain cane, and I rotate the lens. That rotation is key. Makes it that rotation saves me a minute right there
During phaco.
during phaco, because it makes it easier to rotate. So here's my little technique. So basic cases, I think we can do 6 an hour. So here's my little technique. I use my second instrument, I bury my tip a little bit, and then I reach to the equator, and I just bring the two instruments together, and I separate them. And I crack it until I see this orange gap in the middle. In this case, I didn't get it. Incomplete crack. So I go here, and I repeat it. And I spread them, and I'm looking for an orange reflex of the retina. Right now, I'm thinking, I think I have 3 pieces. Let me try and take one. And so I go to segment, which is higher vacuum.
The bottle goes higher.
And so I'm increasing the vacuum capability of this instrument to
Settings change on the power typically.
to pull this chunk up, and I call it lollipopping it, like a charmed blow pop. And then it emulsifies when I stomp on the foot pedal. It pulls it in with vacuum, and then the ultrasound energy dissolves the lens. So we're all good, and we're done with that. Now I think I'll get some of this peripheral stuff. That's fine. And we're out. So that's clear capsule. There's some cortex there. Give them a little more numbing medicine. I usually hydrate this to flush any stuff out. See that little fragment? That one? That was underneath there. Things sequester themselves. That's why I do it. IA, I go in. So this is silicone tip IA. And I'm just going to get this stuff out. I tend to rotate it tangentially. It tends to be less stress on the zonules out here. Instead of pulling it toward the middle, I kind of go tangential. And I usually get the majority of the cortex, and then once I've gotten this stuff out, then I vacuum the posterior capsule to grab the little strands right in here, these strands. So I'm aspirating, and I tend to move it vertically, okay? And I'm moving it vertically, and 99 times out of 100, it works out just fine. But watch as I zoom in here, I grab, I caught it. I identified it within 1 second. There's my open capsule right there. It's a V shape right there. Okay? So I identified it. You saw me stop. The key is the surgeon has to identify it early. Take evasive action immediately. So I'm going to push viscoelastic in because there's now vitreous back here. It's floating around. When I open that capsule, the vitreous immediately wants to come up. Okay? I don't want that because that means I might have to do a vitrectomy. And there's a saying, viscoelastic is cheaper than vitreous, okay? So I want to keep this stuff out of the way so I don't come out of the eye. I keep the phaco inside the eye, or IA here, inside the eye, pushing fluid in, and then you'll see I say, give me the
Find it one more time when it breaks.
Yeah, you would.
Super slow.
Yeah, you would.
You can see him grabbing it looks like grabbing saran wrap.
Whenever the sequencing stops, that means I've recognized it, and I'll say something. In this case, I said, "Can I have the OcuCoat?" And while the eye is in the eye, that's not normal.
Anytime they're putting viscoelastic in with the eye still pressurized, it's not what you want.
Who was with me? I forgot.
Just me.
Kara, okay. Yeah. I mean, everybody did fine. The whole case was, because I went to the other room. This case took 9 minutes. And I think Tricia said, you and Doug said, you had a break? Because I think the timing seemed like it was normal.
Yeah, you came in because Don had asked you previously about the question. You said, "Well, I just
had one."
You came in telling us.
Yeah.
You got surprised.
So it breaks. Let me back it up by 10 seconds.
So the break happened because you polished the bag too hard.
Yeah.
You'll see it at 9
right there.
It grabs it.
So right there, I grabbed it, and I knew right away because I could tell. My view through the microscope is better than the video.
But it lets go.
I'm sure you.
It let go.
Is it easier for you to have a PC break in the center of the bag versus that?
Yes, the capsule is thinnest right here. It's thicker out here. All right. So now I want to maintain my pressure in the anterior chamber because I don't want the vitreous to come up. All right. So I'm just taking my time. We're 4 minutes and 42 seconds into it. I go.
So why do you put it on the cornea?
Because I just wanted to make sure I see everything. This is kind of like, see, the old me used to be very different, but now I kind of go, well, okay, let's just take a look. Let's get it. This is detach, step back, assess the situation. Okay. So I'm just wanting to see everything. So I see my little horseshoe tear right there, and I go, okay, I got it. And I'm thinking, keep my IA in the eye, do not pull it out, keep fluid going through the IA. That's controlled with my foot. And then I go, give me the OcuCoat, and I fill the eye with, I want you to pay attention, so actually go here.
The horseshoe has become
a
big one.
Big one.
Yeah, you saw that.
Yeah.
So I'm filling the eye with OcuCoat because I don't want the vitreous to come forward. But that pressure extends the capsular opening.
Now it's in the center.
And now it's all the way up.
At least they don't need
Okay.
a bag.
But his bag is still intact. That's the thing. The bag is still intact.
Right.
It just has no for the most part.
Okay, so now
Should be able to pull it.
I don't know if the vitreous has come forward or not. Okay, so now I'm going, I think I could use, I say, let me have the I say, give me the lens. And so and I'm thinking, I'm going to put the lens not in the bag. I'm going to put the lens in the sulcus. So what does that mean? So in the bag, the lens is here, right? Everybody get that? In the sulcus, to be true, you make a little capsular opening. And the sulcus means the lens is anterior to the anterior capsule, the optic and the haptics are in here. This is the sulcus. Everything is in front of the anterior capsule. So that's where I'm going to place my haptics, those little arms. So here I'm just putting in the lens. I didn't delete anything in this video. This is just everything in real time. So I'm sliding that haptic on top of the anterior capsule.
Can you change the lens?
No. No. Okay, on one hand, why would you say that?
Because you moved it.
Further forward.
Right. If I put the lens further forward, I'm going to shift the focus further forward. I'm going to induce nearsightedness.
Oh, yeah. It is basic. It's a basic thing.
But we don't want to be just average, right? We want to be the best. So we think. So this is what the surgeon has to think 3 steps ahead. So I go, no factor. I always make my capsulotomy about 5 millimeters or less. I'm going to do optic capture. So now there's still the chance that there's vitreous prolapsing. So now the lens is here. There's still the chance that vitreous is going to come up here, from here, go around somehow, and I'm going to have to do a vitrectomy, and I'm thinking that's going to cost time. And it's not that important, but a vitrector is kind of expensive, okay? It's like $185 or something like that. So I don't, again, Viscoelastic is cheaper than vitreous, all right? So then I put, so I say, give me some GV, and that is what we're waiting on. We're waiting on the GV, because it's in a package, it has to be assembled, you have to kind of blah, 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 a lot of little steps. So we'll just fast forward. Now I've got the GV. So this is the cohesive GV. It's heavy. It's pushing things back. It's stabilizing the anterior chamber. Now I'm going to take my second instrument and I'm going to pop. Okay, think of it, when you think of optic capture, the best analogy is a button. So you want, right now the lens is, let me think about this. It's almost like we're like this. And what I'm going to do for optic capture is I'm going to push the lens, the optic, through the button. And it's going to stay. Because this hole is smaller than the diameter of the optic. That's why the capsular X is very important, because it gives you a bailout. So here I slide the top half underneath the anterior capsule, and then I'm going to pop the bottom half underneath the anterior. The only reason I can do this is I've got all that GV in the eye, and it keeps the anterior chamber real stable.
But the haptics stay up.
Haptics are in the sulcus still.
It's like, so now the body is.
So yeah, so the optic is posterior. The haptics are.
Reverse optic captures like this.
Yeah, and so now I'm going to do my IA. Now, why doesn't vitreous come forward? I'm not pushing against the implant. I'm doing IA. I have no vitreous in the anterior chamber. You'll find out why. I know that. I'm doing IA, but there's a ball valve effect where the implant is blocking. Yeah. So at the end, I've taken out and I know GV comes out of the eye pretty easily because it comes out like a blob. So I hydrate my incision. If it were really complex, I'd say myostat, and that's why I said maybe have myostat ready, but don't open it. Okay? So how do I know if I have vitreous? So some people inject steroid into it, and the steroid sticks to the vitreous. Steroid, it's expensive. And we don't have any, I don't think, in the ASC. Kenalog, I never have used it. All right, so I use the cyclodialysis spatula. If vitreous is going to come up, it's going to go through a path of least resistance. It's going to go through this hole or this hole. Those are the two exterior sites of the eye. So all I have to do, it's almost like the magicians when they slide their hand and there's nothing here, there's nothing here, you can see it. That's the way I think of it. So I'm just going to slide my instrument here, And if there's vitreous coming from behind the iris up to the incision, when I sweep this, I'll see the vitreous. Same thing for this incision. If I go and slide the cyclodialysis instrument here and I sweep there and I don't see anything, there's no vitreous, okay? So that's all I do. Hang on, I want you to see it. So here I'm sliding underneath, nothing. Nothing there. And then I do it here, nothing there. No vitreous. So I go, we're home free. No vitrectomy needed. Yes?
If the lens is in the sulcus, how do you get the viscoelastic out of the capsule?
Okay, the haptics are in the sulcus. In this case, optic capture, the optic is behind the anterior capsule. So what was your question?
How do you get the
Is there
viscoelastic
behind?
behind the lens?
It's there. It's fine.
You just leave it?
Leave it.
Your
not
IOP
bad.
maybe high, maybe low.
Maybe a little high, but it's okay.
It doesn't matter.
It's probably okay.
It will drain slowly.
It'll reabsorb
Yeah,
slowly.
usually it's okay.
Okay.
When a patient has like pre-existing glaucoma and is on glaucoma drops and such, because placing like the haptics in the sulcus, does that cause closed angle glaucoma
No.
more likely? No.
No. Very few things cause closed. Well, we don't deal with that condition very often here.
So low.
When you put in the
We're all
optic
opening.
capsule, how did you know that the capsule wasn't going to completely split?
Well, the capsular excess opening is very strong. And so I'm stressing the capsular excess opening here and here.
I'm talking about the posterior capsule. You had the small tear and then you put in the...
I didn't know it was going to split.
Oh, okay.
But unless it's a circle,
It probably is gonna.
it's going to tear. So that's sometimes we'll actually do posterior capsular excess if we really want to save it. But this is a basic case, and I don't have to change the power because I put the IOL in the bag. The lens optic is in the bag. You don't have to change the power. Okay?
So if you didn't do optic capture and you had it in the sulcus, is there anything that would stop the vitreous from pushing the lens against the iris?
I don't. This happens so infrequently. I haven't run into much problem if I leave some viscoelastic in the vitreous, but I'm not like.
Well, it's not the viscoelastic itself. You have an open posterior capsule. What would stop the vitreous from pushing into the bag and then pushing the lens against the iris because it's in the sulcus?
I think there's still visco in the bag though.
But once it's absorbed,
Are you talking about at this stage right now?
No, he means like
In the future.
later.
so like once the GV reabsorbed,
Yeah.
if you had the lens in the sulcus, you have an empty bag.
Yeah.
The vitreous would then go into the bag and eventually push against the lens, against the iris.
Somehow I don't see that very often. I've never seen that actually.
I guess it just works itself out.
Yeah, I don't know.
It stays open.
I don't know. So I don't have a whole lot of lenses just purely in the sulcus with an open posterior capsule. But let's say I've done intrascleral haptic fixation.
Yeah, well, there's not a.
And there's no bag. I don't see vitreous in the anterior chamber. I don't know why.
These are certain questions you focus on.
Yeah.
Doesn't happen.
It's a valid question, but I just don't see it.
From a patient perspective, will they notice striations like this in the foot, like, you know what I mean?
Probably not.
Probably not. 'Cause it's-
They do sometimes notice the folds, the stria in the capsule when the lens is in the bag.
Yeah. True, but it is pretty close.
So, even all that, because everybody responds quickly, we're out in 8 minutes and 40 seconds. Okay. Any other questions about viscoelastics?
Not all the other viscoelastics that end in visc are cohesive, but clear visc is dispersive. Is there?
I don't even think like that, so I don't even know. You know better than I do then.
There's no pattern recognition here.
I'm gonna go and rename everything.
Yeah. Just know what we use and why we use it.
Yeah. Just some are heavier
Wait,
than
go back
others.
one slide here, and then we got the Amvis Plus, which is both cohesive and dispersive.
Yeah.
And then we got Helon 5, which is viscoadaptive, because we're just making up terms at this point.
Yeah.
So it's all just,
adapt.
it's all just, it's all arbitrary.
Best way to look at it is just how heavy is it? How heavy is it?
Yeah.
Did you go over why you use heavier viscoelastics for denser cataracts?
I use viscoelastic. Well, I want to use a viscoelastic that's going to coat and protect the cornea, because I'm going to be, the phaco is going to exert so much energy in the eye. It's going to stress the endothelium of the cornea, and that'll lead to corneal edema.
Got it.
And if you are not careful,
But
you'll.
like Endocote's not that. You say you used to use Endocote, but Endocote's actually not that heavy in comparison. It's really not.
Well, relative to I use it because it's heavy, but it's mainly coating the cornea. I hope it's dispersive. It is dispersive.
Yeah, it is.
So it's and it's sticky. Like, you don't put Endocote or Clearvis in the bag to place the lens, because you're going to have a hard time removing it. It's going to take longer. It's going to prolong your case. If you don't get all of it out, they're going to have a pressure spike the next day.
Whereas like cohesive is like a long string of molecules, so you can.
Looks like spaghetti.
You can just suck it right back out.
And so the cohesive is, you said it was easier to take out than the dispersive?
Well, I know that this comes out of the eye pretty easily. I know that this comes out of the eye pretty easily. I know that this stays in the eye. This stays in the eye pretty good. They know these. I don't use them. I know that this stays in the eye a long time. Yeah.
That's why I feel like dispersive and cohesive is all
just know what they're good at.
It's just all arbitrary.
I go by how they perform in the eye. I don't actually break it down. I'm using these because I heard y'all talking these terms, so I wanted to speak your language a little bit. All right, let's talk about the instruments.
All right, here we go.
So this is Marie's instrument, and it's a straight instrument. However, we have versions of her instrument that have this bent configuration, which I was watching another video today on Cataract Coach, if you really want to geek out, and they were using a Connor wand of this configuration.
Which you bought. You have one.
And I bought. It's not well received by the user, but it can be used. And it's very easily. It can be used, because the instrument they were using on Cataract Coach this day, it was this in this shape. I use this one. Jo uses that one. In reality, I use all three. They just have a slightly different shape. This is more broad at the tip. This is like my chopper is like this, where it's all lined up. Jo's chopper is like this. Mine's like that. His is like that. All right. Iris hooks, IE sleeves. I think we're going to use MSI.
I ordered. I need to add to the sheet last night.
Sheets glide.
Where?
MSI.
MSI.
Those are reusable for how long?
10-ish.
10 to 20.
We're going to change them out at the
It's
same
kinda
time
like
at like the
needles,
phaco
right?
needles.
Yeah. So same schedule as the phaco.
Weekly, it needs to be weekly.
Yeah,
Fine.
ordered the Hondo.
Fine. Sheets glide. I use it for DSEC. Does Jo ever use this?
No, we kept it. I don't know why. We don't really. I've never seen it.
Do the other doctors use this?
They use it for Vitreous.
Okay. I use this to manipulate the foot plates of an ICL. Phaco.
That needs to be. I took it off. That's outdated because we
Okay.
switched to a new.
Phaco needle. KDB. It's used for a procedure called a goniotomy. It's a subcategory of a procedure called MIGS, MIGS, microinvasive glaucoma surgery.
So he just tried to.
Yeah. So, yeah, I'll show you a video on that. All right, quiz for the nurses. What's this? Only nurses answer. What's this?
I mean, it looks like a disposable artery tip.
Pro tip, it's a blade of some sort.
Is that the blade? Is that a beaver blade? The crescent?
Crescent.
Yay!
Crescent blade. Crescent blade. We're playing flashcards.
What does it look like ours?
We don't have it in this. It's a wrap.
And you hold a real instrument.
I don't know if it's in
It
here.
wouldn't be in there. It wouldn't be in there.
Okay, what's this?
It's a
Diamond.
Okay,
diamond.
also known as a diamond keratome. What's the diameter on this?
2.8.
Diamond blade. What's this?
The sapphire.
Sapphire. What's the diameter on this?
1
Good.
Yay!
What's this?
caliper.
Yes. What's this?
Bulldogs.
What's this?
AC maintainer.
Move. Okay. Oh, dang. Access marker. What's this?
I did update that, but it's the same.
It's like an insert. It's like the.
Looks like the emerald.
Emerald.
Yeah.
Okay. What's this used for?
And that Bliss maybe inserter?
I think it's Bausch and Lomb. Yeah, Bliss. What's this? This is. Oh crap. Okay.
Yeah, that's an
Okay. So it's an Ahmed capsular tension segment. I'll show you how it's used. What's this?
CTR.
Good. What's this? Good.
Nicely done. Oh, well.
What's this?
Now we're getting hard.
The reverse
This little.
Versinski. What's it used for?
For
Sorry.
Yeah.
For DSEC.
DSEC or DMEC.
Is that what you used for the KDB instead of the KDB?
He used the reverse. He used the reverse of reverse.
I used the Sinski, yeah.
The regular.
So how much is a KDB? I forgot.
390.
390. Okay. All right. Oh dang! I should. Well, these are utrata forceps. What's the step of the surgery that it's used for? Right. What's this?
Whoa.
Why is it not a smooth blue?
It's not smooth.
It has these little teeny teeth at the tip. 0.12 a teeth. What's this?
Oh, it's gonna be hard.
Yeah, that one's kind of hard because you'd have to really.
Yeah.
Donenfeld.
Good job. Yeah. Jay taught me the duckbill.
For those of you with small children, I'm having flashbacks of what's this? Apple. What's this? Banana. Okay. So it's the Donenfeld. Yeah. What's this? Yeah. What's this?
That one's hard.
I call it something.
What's it used for?
Is it a
The implant.
no?
We've used it in the past 2 weeks.
For what? Is it a specific tray?
Corneal surgery.
Oh, it's an eye prism.
Yep, you got it. You were right.
No.
You're right.
It's a hoe.
Yeah, that's why I said it's a thing that we call it by an
We call it by a
affectionate
different
name,
name, but it's called an endothelial stripper.
which is not necessarily better than.
No, I use this as
I just made that.
I use this as the stripper. This is the hoe. Yeah. This is the stripper.
No, I'm not kidding. In the middle of surgery, we were talking about strippers and hoes.
All right, what's this? Push pull, also known as Kugelin iris hook. What's this? All right, what's this?
Well, that's not.
We don't use it anymore.
Yeah, that's not fair. We don't. Yeah, you have
What's this?
That one might be hard because it's only just the side.
It is a
profile.
whoever said second instrument.
Second
correct.
instrument.
Yeah, that'll work.
What's this? We use,
We
yeah.
just took all those out.
Oh, we took it out. Lester.
Yeah.
What's this? Good. Next.
Oh yeah, it's kind of hard.
That's your
Yeah.
Yeah.
second instrument.
What's this?
There was like scissors.
These
You're gonna have to go. If you can't see, you might have to.
Yeah, we rarely use them. These are corneal scissors, Van Ness scissors. They're really tiny. In fact, I should use them if I ever need super fine scissors in the eye. Not quite right, but they're used when we did more full thickness transplants. I would trim the donor, any residual tags of donor tissue on the donor button. I trim it with this. Oh dang. Okay. Okay. What's the, we don't the corneal scissors.
Yeah, that one's going to be kind of hard to see.
Sinski hook.
Yeah.
That makes sense because.
Curved or straight. I'll show you where we use it the other.
That you're using the Sinski.
What's this?
Are you going to order less KDBs?
Yes.
We'll probably use up our existing ones.
What's this?
The medium
needle holder.
Needle holder. So when the doctors call for like plain gut or whatever, silk suture, it has a bigger needle. Let's not use our fine needle driver in the cataract tray. Let's use a bigger one, because when they hold bigger needles with these, they'll bend at the tip. And when I need to like bury tenonylon, I'll use this and it won't grab it because it's been bent because it held a large bore needle. Okay. Yeah.
Bladed speculum.
Yeah. Yeah. What's this?
irrigating.
Yeah, nice. What's this?
A spatula.
Cook spatula.
We used to have one. I don't even actually know if we have one.
Okay, these are important. What's this?
Scissors?
That's hard because you can't tell.
This one's hard between like
that
the
one and
first
the
Oh,
one and the.
That's true. IOL cutter. What's this one?
IOL cutters are bigger.
Hoffman.
Yeah, it looks like.
What's this one?
This one's got a long name to it. Well, not really.
No, not really.
Think.
It's the same name as a tension segment.
These are probably
I think I remember
the
this mic.
smaller scissors. Fine. I use this for iridotomies or cutting suture in the eye. What's this? Yeah. I use this for pulling strands of trabecular meshwork or doing a posterior capsular excess, or when the capsular excess is about to go around the zonules. It grabs super exact, super strong. It won't slip.
On Monday, you asked for the almond forceps for that instead of the capsular excess.
What was the procedure? Oh, but I was trying to grab a fibrous strand of cortex from the bag in a lens exchange. That's all. All right, these are what?
MST with D.
Yep. What's this? I use this for suturing inside the eye. What's this? What's this used for? What procedure is this used for?
ICU.
Oh, yeah, ICL.
Correct.
Yeah.
What's this?
Yeah.
What's this?
Is that the Connor wand?
Yes. Let me see. What is this? Oh, what's this?
Oh, the sweeper.
Correct. Polish the posterior.
On that forceps, would you only use that when you're doing the OBMED segment?
No. I use this. This and this can be used very similarly. They can be used to grab anything where you don't need teeth.
Okay.
So I could use them for, let's say, I'll show you some cases. I want you guys to know what the patients see. So they're all sent this video, which tells them what they need to do before their surgery, where to park, etc. You know, bring your drops, buy artificial tears, dress warmly.
Are they texted this link?
Yes. Emailed and
Okay.
Okay.
They
Soon before surgery day is.
Some of them don't get it or don't watch it, but I don't know.
3.
We used to have all the patients watch these in pre-op. They don't do it now, do they?
No.
Because
It's too long. It's so long.
Okay. And are they sent this video?
Correct.
Yep.
Oh.
So this is to address all the questions of what to. So this is what to do before surgery. This is what to expect during their surgery and after their surgery. Okay. This is helpful to kind of understand the instruments. You guys, thankfully, watched most of these. What do I see through a microscope before YAG capsulotomy? I see this crinkly wax paper texture. Immediately after I do a YAG, it goes away. That's why they see hazy, filmy, waxy, cloudy.
How would you classify the PCO on that eye?
This is the panoptics. Panoptics are very sensitive to PCO. This is trace to 1+.
Wow.
I know, right?
Okay, so we need to talk about money, because this is a business. So there's a CPT code for each procedure performed in the ASC. Does anybody know the CPT code for complex cataract surgery? Don't go to that. Only nurses. Only nurses.
6'6"?
You got one more item. That last one is
You're right.
66982. So when I say, or hopefully the doctor doesn't say during surgery, or have to say during surgery, complex,
You just say that.
say 66982. And what qualifies as complex are vision blue, CTR, iris retractors, capsule hooks, things like that. What doesn't qualify as a complex is anterior vitrectomy, dense nuclear cataract,
Or length of the case, I guess.
length of the case.
How much visco you use.
Yeah, does not come,
doesn't
no.
matter.
It's, yeah, it's.
Counterintuitive, really.
If we have a 3-hour case but not use any of that stuff, it's still normal.
Sometimes if you're like, this is a complex case, well, that's something that's documented at the time of ASC, so where would you expect us to document that? Like, on the schedule?
Okay, so the problem there is,
I'm looking through their undilated pupil through a slit lamp, which gives me one view. In the operating room, I'm looking at their dilated pupil through a different microscope, which gives me a very different view. So if I do complex, it's to indicate two things, one or both of two things. Number one, should be the last case. Number two, we might need extra stuff. But like somebody asked me yesterday, are you going to need this? I go, I don't know. Give me a minute. And that's when I look through the microscope and then I tell you, no, we're not going to need all these things because I can't get that view. I guess if I dilated everybody before surgery, I would have a better idea, but...
Well, there's sometimes, it's very rare, but you're like, this is going to be complex. I'm like, okay. And in my head, I'm like, okay, so whenever I'm scheduling it on the schedule part, is that where you might complex? So
Yeah, we should schedule it as complex. So
Well,
that
the problem
way they
is,
know
yes,
that it needs to go at the
yes,
end.
but there's complex reserved for a 66982, knowing
Right.
you're going to use trypan blue. Because there's a lot of cases he could use a million other things and it doesn't qualify as a 66982.
It could just be a
We are
complex
erroneously and false billing a patient that.
So
that's
we-
the issue. Complex is only for the 66982 tag.
Right.
Otherwise, you need to put complex as in complicated. We probably should use the word complicated.
Okay, do you know the CPT code for regular routine cataract surgery? 66984. So let's write those up. These are so important because I don't think the doctors, I'll just say, I know the doctors call certain things complex and want to bill it as complex, but it's not. Okay?
She'll call it complex just because it's dense and that doesn't matter. It doesn't matter.
66984.
This is complex.
82.
This is routine.
My loop is a no.
I don't think the use of my loop counts either.
No, it does not.
Yeah, the nurses
It
in the
doesn't.
operating room, like, they have to change your operative note one way or the other.
Right. So I'm going to tell you, if it says complex in iMedicare, and I go, oh, this is 66984, then change it to the regular op note, which I think will change the billing too.
Well, right, and it's the nurse's responsibility to go in there. If the case does turn into a complex case, we change the op note and we go into the CPT codes and change it to
Thank you. But because certain doctors may or may not know what complex is, I want the nurses to know so we bill appropriately and accurately. Okay?
Yeah, so even though she pre-certed and it's marked as 66982, we went in there and it was routine. We cannot bill it.
Right.
I don't care how long she spent phacoing.
Right.
It doesn't matter.
Right.
We didn't use trypan blue. We didn't use the CTR. We didn't.
Right. But she never tells you until you're
No,
like
she
in there.
Yeah, no.
And it's like the last second.
So I really, ultimately, I would love to know how many 66982s we may have accidentally billed that were not.
So I try to tell you to give you enough time to change it in iMedicare such that by the end of the case, everything's already done. I'll tell you probably before I put the lens in.
Okay. Nurse slides show us.
Yeah.
We can show you the computer. Okay.
Okay, so for each procedure, there's a physician charge and an ASC charge.
Facility.
Facility charge. Yes.
Sorry, may I ask a question regarding this new Sinski hook method for the KDE? Does that change what we need to be?
No.
No.
It's the same procedure. It's like if I were able to do phaco without using a phaco, but I could use just some other instrument, it's still cataract surgery.
Yeah. The code
So you
that
will still code it as a KDB?
Yeah, so
Because it's goniotomy.
Yeah,
Okay.
the code 65820 just means goniotomy. Whether you use a KDB, we're just losing out because we're using a KDB.
Right.
Whether you pull it out, you do whatever the heck you want to do, it's just a goniotomy.
It's like doing cataract surgery without the femto. We were paid the same whether we use femto or not.
If you lens looped it out,
So maybe we should just change it to goniotomy.
yes, so I talked to Amanda, in our system,
Yeah.
we just labeled it as KDB,
But
but
the
when
thing
you
is-
Google 65820, it's goniotomy.
We just started doing it this week, and I don't know what the other doctors think of it. That's the thing. So I
think they all did it. I don't know what they think.
I
They
was gonna do a KDB.
J.O. liked it. But we didn't like it?
J was good.
Okay, so let's just talk about these things. Who controls the reimbursement or payment amount for each CPT code?
Insurance, Medicare.
Medicare. CMS, Centers for Medicare and Medicaid Services. If the physician and ASC are charged a fixed or flat rate or paid, I should change that, they're paid, the physician is paid and the facility is paid a fixed amount per procedure, are the reimbursements or payments to physicians and surgery centers going up over time, staying the same over time, or decreasing with time? Okay, so when I came out into the world and started billing patients for my services for 66984 cataract surgery, the reimbursement was, I think it's close to $700.
In 1997.
In $1997 with a annualized inflation rate of 3%, let's say. So over time, because of inflation, you ever heard of that word? Because of inflation, the cost of goods go up. So this chart only goes to 2018, but over time, reimbursement went down. And then in 2020, it went down further. So over a 23-year span, the reimbursement went down. Meanwhile, we were able to do well, not because of the government, because of one of the best pieces of legislation, which is 2005, where they allowed physicians to charge the patient for elective services. Prior to 2004, and I was doing surgery in this period of time, I couldn't charge the patient more to give them a premium lens if they had Medicare.
Oh, I didn't know that.
Yeah.
Wait, say that again?
It was illegal to charge them.
And that's why you have the ABM, right?
Well, no, it's just 2005 is when CMS, they opened it up.
That's required for my CMS.
They did exist.
Well, I
Crystal lens and restore.
It wasn't that great.
So the origin was,
still-
the origin was the crystal lens came out, and then the crystal lens people worked with a politician in California, Chris Cox, and they changed the law, which changed a lot. Okay. Anyway, so here's the ASC reimbursement. Over time, it didn't go up. Let's talk about this briefly. Hospitals always get paid more than surgery centers. I'm sure there's a lot of reasons why. Maybe they have to stay open longer, etc., which is fine. So I asked Amanda, I said, hey, what are we being paid in 2022? Remember, so over time for cataract surgery, it was $675 or so, $700, and then went to $557, and then it went down to $550 in 2020. So I said, Amanda, what are we being paid now? So it's broken down to cataract surgery for the physician and cataract surgery for the facility. Medicare sets the pay. Private insurance tends to pay more than Medicare, but they pay based on, they peg their reimbursements as a percentage of what Medicare pays. So Medicare pays for cataract surgery, $551. The facility always gets paid more than the physician. So the facility fee is a little more than $1,000. What about YAG capsulotomies? 66821. The physician gets paid $322 per eye. If we do both eyes, we don't get double of that. We get 50% of the first eye for the second eye. So back in the day when we weren't as busy, we would do one eye at a time, have them come back, do the other eye, so you get 100% of the reimbursement. But we're so busy now, it's more efficient for us to do both quickly, get them done, so we cut down on office visits and we can see new patients. The facility gets paid, in this case, less than the physician. What about cornea transplants? There's a physician fee, a facility fee, and a tissue fee. The physician fee, the facility fee, and the tissue fee. This is roughly the cost of the tissue, okay? You don't see it. You see that these procedures take time in the operating room, 30 minutes or so, but there's a lot of time downstairs in the clinic that we have to manage them too. Blepharoplasty, that's the physician and the facility. So the question that only the individual can answer is, what's the best use of time and balancing time and reimbursement in the ASC? What are some of the costs associated with cataract surgery? You would think it's simple, but it's not. There's a lot of costs. We have to pay your salary, pay a pharmacist, pay for Mary, pay the expediters, pay the housekeeping, pay for your scrubs, the PPE, the licenses, inspection, AAA costs. I don't know how much, forgot. 10,000, 6,000, I don't know.
For the
Survey,
inspection?
yeah.
It was like, you paid like a $900 fee and a $13,000 fee.
So yeah, it's rent, utilities, the AC, it's nice and cool in here, but AC is not free. Furnishings, you ask for something, we get it. All the things we consume, dilating drops, Proparacaine, Valium. Thankfully, Valium is very inexpensive. Our table, the microscope, the machines, the packs, the lidocaine, BSS, surgical instruments, sterilizers, viscoelastic cystotomes, the implant. I listed pack twice. Gloves, betadine, Vision Blue, CTRs. These all have a little cost. That's why we're always wanting, because we get paid a fixed amount, you want to minimize your costs.
You meant to say ophthalmic pack on one of those.
Okay, fine.
Yeah.
It's fine. And all the equipment comes with a service policy, yeah.
When you ask for an additional like viscoelastic or whatever, does that mean that we can bill insurance twice for that? Or
Nope.
is that an out-of-pocket expense?
You
If
can't
I
even
use
go
5
from insurance.
Viscoelastics, I still get the same $550 physician fee.
Yep.
Yeah.
What do you get paid for those aborted cases when they enter the?
I don't know. That's an Amanda question.
I'm just curious.
Yeah. So what gives us our freedom is the elective surgery. We're doing fine. We really don't have anything to complain about. But to kind of give you an idea of why I don't do regular eye care, I'll just share with you because it's true. I looked it up last night. Anybody guess what it costs per hour to operate this organization?
5,000.
You're right. It's a little.
Or just this one?
The whole practice.
The whole shebang.
It's a little over $5,000 an hour. So just to be here and have this meeting, that's
$20,000
Yeah.
for the production.
15 minutes of cataract surgery, someone's forking over
That's right. That's what.
$6,400.
Okay,
So 15
now
minutes.
think about it. Think about it.
But it doesn't all go.
What if it doesn't all go?
What if we didn't have? What if we didn't have elective surgery?
Well, I know. Yeah.
You do $5,000 worth of overhead an hour, and
you do 4 cataract cases, and it's $1,500 times 4. You made $6,000 for 5. It's like it's tough.
Pay your bill.
It's tough. You can't be great.
You'd have to do 10 an hour.
Yeah.
Oh, yeah.
Yeah.
Somehow.
That's just like,
Yeah, I'm just.
Somehow.
So just some big picture principles. Everybody here's a leader. So I sent Jake this thing, a video yesterday. I just love it. It's talking about everybody's a leader. If you work with other human beings, you're a leader. You got to listen to that. It's great. I listened to it 2.5 times. I'm going, there's something to be learned a lot here. Other principles I want us to all be mindful of. Be humble. Just be open to new ideas. Keep your eyes open. Listen. Communicate. Be kind. Treat other people with respect. If we make a mistake, if the surgeon makes a mistake, if housekeeping makes a mistake, if Doug offends Kelsey, you take ownership of it. You take ownership of it. It was a sweet moment. It's good. You got it. Everyone was clapping downstairs yesterday. It was good. All right. So hold yourself to the highest standards. It's not about, Doug says it's not about me all the time. It's not about you. It's think above yourself. Great leaders put others before themselves. Cover and move, build relationships. So I always, what I've learned is like, if let's say something annoys me and I want to tell the person, I always think, is this going to help the relationship or is it going to make it worse? And I have to kind of like detach, check my ego, and say, maybe I shouldn't say that. Because I need to tell them something, but maybe I need to kind of like be mindful. Something called leadership capital. You have to go through every day assuming, like leadership capital is like influence. So you have to go through every day almost like, I have no leadership capital. So what am I going to do today to earn a little leadership capital? I can either earn it or I can make a withdrawal. And I don't have that much to withdraw on a daily basis. So always build that relationship and think about that. Just take ownership of everything. This was a little clip. If you follow Echelon Front, which is that company that made that poster on Instagram, this is an example of little things that I'll see on my little Instagram feed. Let me see if I can hit play.
What is the most important quality leader? It's humility. Because when you can't check your ego, when you can't be humble, you certainly can't adapt or innovate. You can't listen to anybody else. You can't learn from anybody else. You can't educate yourself about new methods of doing things. You can't implement new technology. Even on the battlefield, when life and death is at stake, we would see egos get involved. You stop losing respect for your enemy. You get complacent. And even if you're in the business world, who's your enemy? Your competition. Oh, we got them leg. Well, you start getting complacent. That replaces creeps in. When you're not humble, when you can't keep your ego in check, you can't self-assess. You can't take a hard look in the mirror at yourself and have an honest, realistic self-assessment of what you need to do to improve that situation. When you can't do that, you're never going to get better. You're never going to do it.
So he's a patient in our practice. So he had PLR. Let's see here. Now I know that y'all put together this, and I'm happy to go over it with you. But like when I review it, there's certain things that I know you're kind of getting off on the wrong track, although it's well intended. So let's say it's 10:30. I'll go over whatever y'all want to go over. I've kind of covered the heart of what I want to cover, but now I want to fill in whatever gaps that you have. And I have innumerable videos that I can share with you.
So basically presentation on your part is done?
It's kind of, I can use my videos to answer any questions you have.
Yeah, we could, what if that list of questions that you had before?
This list of questions here?
Yeah.
How is the YAG laser able to target the posterior capsule without affecting other structures of the eye? It uses the laser that uses what we call photo disruption. So the laser energy can be focused onto a single point, a single plane. So the way we describe it to the patient is you have a cloudy capsule. So I say this is the front of the eye, and then I usually use a different color, and I outline the lens, and I say the lens is inside this capsule, and the capsule is clear immediately after surgery. But as time goes by, the capsule can grow cloudy, and that fogs your view. So we can focus a YAG laser on the capsule, and the energy will come into focus. The energy will pass through the cornea, through the implant, and then come into focus at a single point. And we can apply those points in a pattern. And it opens the capsule. And you might see fragments of the capsule floating in the eye as floaters. But let's show you...
It's kind of like killing ants with a magnifying glass.
Is it a measurement of how far to go in?
Probably.
I'll show you videos. Doug, 43. We're good.
So there's millijoules.
There's settings. There's like 0, 1.
It's like power. Wasn't like YAG capsule in plain English?
This kind of takes a long time, so...
But we make it surrounded by the capsule, but the capsule has turned cloud.
So
little floaters. Although their overall view is much clearer, this is a live view of the eye. You can see the implant in the eye, surrounded by the capsule, but the capsule has turned cloudy.
Can you appreciate the cloudiness of the capsule?
Like somebody has placed fingernail polish on a clear lens.
So I focused, there are two beams of light, and I merged the two beams into one, and that is the focal plane.
Placed fingernail polish on a clear lens.
What would you grade that?
So the YAG laser
Trace.
is brought into focus just behind the implant. Small pulses are applied to the cloudy posterior capsule. The energy of the YAG laser creates a small microburst that allows us to open the capsule exactly where we want it. The laser passes harmlessly through the cornea and through the implant. We assemble a series of these small YAG laser pulses and create a expanding circular opening through which the patient can gain a clearer view. You can see small fragments of the capsule are being suspended behind the implant, and they might be seen at a later time as small floaters. These floaters usually dissipate over a period of days to months. The patient feels nothing during the treatment, just mild vibrations, no pain whatsoever. Here you can see a side-by-side view, before and after, of the cloudy capsule on screen left and the opened capsule on screen right. This patient did great, and their cloudy vision was.
What else?
And nothing happens to the patient's eyelid if you zap the eyelid.
Correct. Like I could put my finger and YAG it, and it's such a small amount of energy.
What happens if a doctors do nick the lens? Like
It hits the lens, and as long as you don't pit it right in the middle, it's probably okay.
Does the machine make a different noise if that happens?
I think it just clicks whenever you fire.
You don't hear the snap, you hear
There's like a dud.
It's like a dud.
It's a dud sound.
Uh-oh.
Yeah.
I feel like I used to hear that a little more.
Oh,
Just wondering. I had a feeling
Understood.
that the machine made a different noise.
What does it do if that happens?
It makes a hit in the lens.
No, I mean like what?
Visually, their optical quality is diminished.
Okay, any other questions about, Grace, yes?
Yes, so what purpose does knowing the lens that, like when we write in the YAG book, like, oh, there's how to basic or Panoptics, how does that help inform how you're performing the YAG?
It doesn't really.
Oh yeah, we don't do it downstairs.
Can we not do that anymore?
I think that's an Amy Lisa question.
If you have the document.
We don't do it down here, we just do name, date of birth, energy, and eyes.
I was really not paying attention, I'm sorry.
Well,
It's
when
in
you
the
write on
lens.
the YAG book, you write what type of lens for him.
Yeah,
was it
that they
machine?
had before, like implanted.
Why does that matter?
Yeah, they were asking, why does that matter? And I said it really
Do they
doesn't.
track like how many more premiums versus basics you have to do?
So maybe we could stop doing that. I don't need it.
It just matters to the physician. It just-
Yeah, we're not using it for any reason.
Yeah, I don't think the doctors care because they're never going to go check that list.
No, yeah, you can see it as soon as
It's
you're in
fine.
there.
I'm fine with it.
We'll just stop them.
Okay, fine.
Hooray for efficiency. Good job, Grace.
Good job, Grace.
What else?
Okay, next question. Would you be able to walk us through a video of a posterior capsule break? Would you be able to point out the ciliary body and zonules on a video shot from one of our surgical cases? How is the surgeon able to discern the patient has loose zonules? Okay, God, I have many videos of this. Loose zonules.
While you're looking for that, is there ever a time where you make an opening in the posterior capsule where it's so large that it can shift the lens, like placement over time?
I could, but I would choose not to. Like, here's an example of a posterior capsulorhexis.
Dr. Shannon Wong in Austin, Texas. This is a manipulation using the silicone tip irrigation and aspiration tip.
So this is the posterior capsule.
You can see there's a reflection in the posterior capsule showing that the
How do you
plaque
notice
is
the posterior
fairly
capsule?
fibrous.
Well, a couple things. This is from 2017. We didn't have a current video system, which is more high resolution. So you're not seeing it as easily. I saw it. You could. We see. Yeah, we can focus in and out, and judge different structures in the eye. It's like a portrait mode on a camera. You can adjust exactly where you're focused.
Why are you choosing to do it posterior capsule?
There's a plaque. I can't get rid of the plaque. And maybe this is a premium lens.
And find that the plaque cannot be torn. Therefore, we elect to use micro scissors and then a pair of Utrata forceps.
This is probably before I bought the MST Capsular Access forceps. So as time has gone by, I used to be more cheap, and now I just get what I need. So
During the original surgery of you putting the symphony lens in for this?
yeah, symphony lens, yeah. So I didn't want that plaque there. Now, do I have to do this? No. A lot of times I'll do things just because it's almost like, there's an analogy like, it's a golf thing, but like Tiger Woods, when he would play at some golf courses, he would intentionally do things to prepare for the major championship. He didn't have to do it on that course, but he was doing something that he knew this would help him on a major. So like, I could just do YAG, but I remember around this time, 2017, I saw somebody do posterior capsular access, and I go, that's a trick I need to learn. So I would find opportunities where I do it. Like whoever was with me, I was pulling that strand, and you were asking me, I was telling you, I didn't have to do that. I was just playing around. But I'm trying to figure out, like, what can I get away with? Because there's going to be a situation where I'm going to need to know something, and I'm just trying to, like, get an extra trick shot.
Aren't you running the risk, though, of breaking that capsule?
I broke it intentionally. But,
Okay,
I have lots of viscoelastic in the eye. It's very controlled right now.
We're carrying within the...
I've got like Heal on GV in the eye.
And find that to be a challenge. Therefore, we elect to go peripheral to the plaque using a cystotope to widen the posterior capsular axis. We then rotate our...
But I'll just show you. Long story short is, this allows you to put the lens in the bag because it's a circular opening and it won't extend. If it's stellate at all, it extends. That's when we used to inject medicine, steroid, antibiotic, in the eye. We found that was not good.
Now, I asked this question, I don't know the answer though, but why wouldn't you just do a posterior capsular access on everybody?
It takes time.
Oh,
Yeah.
it takes
There's
time.
a lady who does that. There's a surgeon who does that.
Takes time. So zonules. The question was zonules. Let's go to.
Complication.
Yeah, it was a complicated. Kelsey and I watched one where it was
complex eye surgery cases.
It's like right on.
Wait. Hang on.
That's the best one. That was the worm.
Oh, there we go.
Loose on. This is old. 2012, 20. Let me find something recent. Can I filter it by recent?
It was one of the guys. You had to do a suture fix.
Somebody who has no zonules.
Oh, there you go.
Wow.
So wait, how do you know?
So here's the...
You can see that there's a gap.
The bag is completely separated away.
Oh, I watched this video last night.
Yeah, so basically I've got to create zonules, and the way you do it is you use that Ahmed segment, you put it in, and this is where you use your micro instruments, and usually make an incision 2 millimeters posterior to the limbus.
That's it. You have to put it in the bag.
Exteriorize one end of the cortex.
So when you use the Ahmed segment versus the CTR, I understand the reasoning because there's just a segment, but why can't you just use the CTR?
CTR only does this. It doesn't actually. So
Couldn't you technically suture the CTR?
So let me show you. So this ends up being a very stable structure. It's time consuming, and it requires more effort. Okay. Let me show you an example of where to stabilize the lens, and then basically I put a CTR in when I have like 2 or 3 clock hours of loose zonules. I put an Ahmed segment in when there's more than 2 or 3 clock hours of loose zonules, and I'm worried about long-term stability. Because if you have like 4 clock hours and you put a CTR in, it may look good now, but the remaining 8 clock hours of zonules, they're going to get stressed over time, and they may unzip, and all you need is like another clock hour to unzip, and then one more, and then that lens is kind of like all over the place.
So it's a long-term thing.
It's a long-term thing. Yeah.
I always wondered about that.
So there's
never really
Yeah, just a little bit of CTRs.
So this is a little bit, yeah. What else?
So the Ahmed will stay in the.
Ahmed will stay. Vortex stays for a lifetime.
Okay.
It's like rogue, I guess.
Why do you use Westcott when you sit up top? Because if I want less than 1 diopter of flattening, I need to reflect the conjunctiva and enter more peripheral. So that's why I reflect the conj there. Whereas the cornea is, remember the cornea is like an oval? If I sit peripherally, I can get less effect just because you get, for a 2.8 incision, you get about 0.1 of flattening. For a 2-point incision, you get about 1 diopter flattening. So the cornea behaves differently. Can you please walk us through process of marking and how it dictates your OR plan for using the axis marker in the AK? All right, so that's pretty routine.
It's like you don't need to mark a spherical lens.
Yeah.
Does that make sense? You don't. There's no toricity to plan for, so you don't need to mark a spherical.
But I feel like it's rare
Not
that
necessarily, because if you use an LRI.
LRI, yeah, but if he's not doing, if it's just plain old, there's nothing, he's just doing it, you don't need to mark. It's only if you're doing anything related to astigmatism that you need to mark.
That's in there.
In this video, I thought I'd share my technique for routine cataract surgery.
That's what we're asking about. It's really the outside marking, right?
So the eye rotates when you lay back, and I don't know which way it's going to rotate. So I want to make sure I mark them so I know how they are when they're upright in the world. So I mark them, and then let's say this patient needs astigmatism management at axis 100, 95 to 100. Then we've marked this and we place it. Our original marks are here.
Preoperatively, they have about 0.3 diopters of astigmatism at axis 105. Because we're operating on this patient's right eye and sitting temporally at axis 180, we will place a 2.0 millimeter limbal relaxing incision at axis 105. After we mark the patient's axis, we place additional lidocaine followed by Ocucode. We use a 600 micron guarded LRI diamond to make the limbal.
That's why I mark, because I want to make sure I line everything up properly.
But I think I think some of the main questions are outside of the OR. When you come to each patient in pre-op, why do you mark the non-toric patients?
Why do you mark?
Oh, because these are PanOptics patients or whatever. They want it exact, and it's going to tell me where to put my incision. It may not be it may be at axis 30. I put my incision. I might do an AK instead of a toric. So this patient needed an AK. I need to know how to mark them. If I didn't have this mark and this mark, I wouldn't know that that's axis 105 or whatever it was.
So you're the only one that does that.
Because they don't do AKs, right? They don't do AKs? What?
Who does?
Okay, so they don't mark them outside?
Not all of them.
3 and 9? They don't mark 3 and 9?
I've never seen her do an AK in surgery.
Yeah, I don't think I've ever seen. I don't think.
Does Jado mark 3 and 9?
Only
for
on toric.
On torics. He doesn't do AKs, right?
No.
He would rather, he says that he'd rather do something down here than have an untouched eye down here. That's his rationale.
That's fine. I don't want to see him any more often than I have to. So I try to do it all at the time of surgery. So then, Marie marks her 3 and 9, right?
She only marks if the astigmatism is greater than 0.4.
Right.
On premium
0.4.
lenses.
So if it's a toric lens, does she mark 3 and 9?
Yes. All torics and
All torics,
astigmatism more than
non-torics, only astigmatism is greater than.
Okay, fine.
But what if it's like 0.39? What about 0.41?
Well, then we're splitting hairs. We're splitting hairs.
I mean, it's all really guesstimation anyway. I mean, it's not like you're using a ruler.
Astigmatism management is somewhat of a inexact science.
Does a toric lens cost more than a non-toric
No. Well, the toric panoptics and the non-toric panoptics are the same. Toric vividity and non-toric vividity, the same. But any lens that has toric power costs more than a basic lens, monofocal lens.
Why would somebody use an eye-enhance, not an eye-enhance toric, an eye-enhance?
Eye-enhance more expensive.
It's supposed to have
why do people choose that?
It's supposed to be kind of like a Vivity.
Yeah.
I found it not to be. I found it to be more crystallens-like, but most of you weren't here in the crystallens. So it doesn't give much depth of focus, but it's marketed as such.
Okay.
But it doesn't, I haven't found that.
Well, you've only used the eye-enhanced monofocals for the IOL exchanges where the patient originally had an eye-enhanced monofocal.
I rarely use eye-hands. Like the reason why I used it on the younger guy is it's the only lens that was that strong. Because he had a short eye, he needed like a 34 diopter.
But he was a toric lens, though. He was a toric.
He was toric.
Yeah.
On one eye. On one
Did
eye.
you change it? I did his pre-op and
Eye hands.
He did use different lenses.
Yeah.
For each
Oh,
eye.
yeah,
He had a
that was
lazy eye,
the
too.
That was the antibiotic eye.
Oh, okay, I remember.
Yeah.
Because it only came in that power.
Yes.
Yeah.
Yeah. He technically needed 35, but it taps at 34.
Yeah.
Oh.
Yeah. That's how short his eye is.
Grace, I sent you another question.
Okay. Could you talk about the progression of like glaucoma management and when we would do what sort of procedures and when would we escalate that to X, Y, and Z?
Okay, so the KDB and
Or goniotomy is goniotomy. Oh, there's another one. Iris prolapse. Y'all wanted to cover that. Where's my KDB?
There's the Sinski hook one, but I don't know if
I think it is a YouTuber. So the KDB is used, we just started.
Traditionally, we use the Cahook dual blade or KDB to perform goniotomy, MIGS, or microinvasive glaucoma surgery to help reduce intraocular pressure in patients with mild to moderate glaucoma.
So it's indicated for mild to moderate glaucoma. If you have very severe glaucoma, it's probably not going to be so good. Probably that's when we refer them to JO or another glaucoma specialist because they're like going to go blind probably, and I don't want to be the one that does their last surgery because I'm not like a glaucoma guy.
In clinic, they start with, they would have already started with drops and stuff. Is there
Probably. KDB is mild to moderate glaucoma, and I actually tell them you're still going to be on eye drops. It's not a cure.
Share a case in which I chose to use a...
So this, I mean, I only did it once. Maybe I'll do it and it won't work so well, but this was like so easy.
Instead of a KDB to perform the goniotomy. Here we can zoom in on the pigmented trabecular meshwork band, and we place the tip of the Sinski hook through the trabecular meshwork, then slide it toward the left. Unlike using the KDB, since the tip of the Sinski hook is smooth, advancing the Sinski through Schlemm's canal is smooth and frictionless, and as a result, the eye does not seem to rotate with advancement.
See, so what we're doing is pushing through this meshwork, hitting the back wall with the Sinski hook, and then cutting. It's a goniotomy. Okay, so that allows...
We augment our goniotomy by
an opening, decreased resistance, and it's easier for the fluid to escape out of the eye, and that lowers the pressure.
Passing the Sinski hook in both directions. This technique may prove to be a nice alternative to goniotomy using the KDB.
Do an SLT after this?
You could.
You can always do an SLT. It's like,
Yeah.
it's repeatable.
Yeah, SLT is a good thing. There was a question about iris prolapse. How do you manage iris prolapse? Who asked me that question? Dawn? Is Dawn here? I think there was some question about iris prolapse. So I thought, oh, we had a case. So this was our lens exchange from last week. So we filled the eye with GV. Here are IOL cutters, MST forceps with teeth. But we have to put a lot of GV in the bag, and that is doing the following. This is a lens exchange. So in order to float the lens out, we've got to push a lot of GV into the bag, and it actually pushes things upward. So now you've got this force pushing the iris upward, and it wants to prolapse out of the eye, iris prolapse. Now I'm in a little conundrum here because I need to create space. If I'm cutting the lens, I don't want the capsule to be, the posterior capsule to be anterior. I want to push it back, so I've got to keep stuff in. But then it's pushing the iris out, so then we have to kind of manage it. I'm sure the other doctors manage it differently, but I'm using GV again, which is heavy. I'm trying to push weight against weight, and it kind of works, but it kind of doesn't. See? Two equal forces, they're not really doing anything. So then I go through my secondary incision, cyclodialysis spatula, and I tease it back in. But you can do damage to the iris if you're not careful. So now I put GV on top to push it back, and I'm trying to pull this fragment out. And my concern is if I pull and the iris is incarcerated or prolapsed in the incision, I'll rip the iris, I'll cause a cosmetic defect, and they'll be pissed at me that way. So I don't want that. So I realize in this particular guy, I go, see, it's wanting to come out. And I don't want to damage his iris, so I do it again.
So when it comes out like that, it's just like kind of ripping off?
It's prolapsing. There's pigment on the posterior surface.
So it's like inside out.
On the iris, and the pigment is flaking off the posterior surface of his
That
iris.
doesn't really affect anything as long as it doesn't tear long term.
The more I let this happen, the more damage I'm doing it to his iris. He ended up fine, but I'm very aware that I've only got a finite number of chances I can keep letting this happen.
And then it'll be like misshapen.
Misshapen, atrophic, they'll have a hole. Yeah,
Can pigment keep rubbing off too?
Could you have taken it out of a different incision?
yeah, but I'll show you how I managed it, because it didn't, because I'll tell you his iris looks normal post-operatively. But here I just push it back, and I go, I can't, I need to use two hands. So I push some GV in,
That's right.
and now I'm gonna, I think of it as like a, almost like a pick and roll in basketball. I'm setting a screen for myself with the cyclodialysis instrument here in a second. Advance 10 seconds, advance 10 seconds. See, I can't pull it out because it's going to rip that iris. Now I should end up holding it. Hold it, screen, pull out. Hold it, screen, pull out. Now, screen, I'm blocking.
We're not screaming. We're not screaming internally.
And so there's a saying, the iris has a memory. So once it wanted to prolapse, it'll prolapse again and again and again. So you have to ideally prevent it, but once it happens, you have to manage it so it doesn't happen time and again. It's just the end of the case. And
When they come back for their one-day post-op, is it ever prolapsed again?
It can be.
it can be if you didn't seal this incision tight.
He rubbed her. We did the one we did in the LASIK room, and his pupil when it post-op was peaked at his primary. So meaning fluid came out at one point, and his pupil, just like in surgery, whoop, tried to go out.
pupil will look like this.
Yeah, it looked just like that. So we took him in, and she.
So y'all
swept
fixed
it.
that in the LASIK room?
Yes.
Wow.
Well, I think we did it out of
Because we were
necessity.
filming.
But
Yeah,
you
we were filming.
seal
We
it
could not
with-
go up there. So I looked at her. I was like, "Are you comfortable doing the LASIK room? I'll do it with you." And she's like,
That's not usual.
So
"No,
Normally you go back.
no." She's like, I was like, "I baked that."
Just to kind of show you how new ideas happen. So this is our little trip to Plano, Texas. All right, and we saw this is.
It was good. It was good.
I mean, I know J.O.'s fast, but this guy is. Let me give you an idea of what we saw. It was this.
That was the expediter's job.
So he uses the post-op bays as pre-op bays.
Oh, yeah, he does. There's, like only one or two
Two
that
post-
are actually
two
for post-op.
post-op.
But they had like 5 on each side, I think.
So there's the other scrub tech and the other OR.
So what happens if it's a complicated case and he's got like not enough time?
They just wait. I mean, that's what they usually do.
We didn't see any of those while we were there.
He does have clinic. They do say he is lit a lot.
So this is where we came up with the concept of expediters. We got so much at Stellaris, Intramural pre-chopper, expediters,
So yeah, those back scrubs, not the one in the dark.
facilitating flow.
Basically, imagine 2 hours, but you have a second scrub buddy to do all your
Scrub
third
buddy,
work.
Basically,
Right.
yeah, they take, and then, well, that other lady was the sterilization person, like, that's all she did was
STD,
run,
that's
he had, how many say, 15 cataract trays, something like that.
Yeah.
He's got that big
He had
machine.
a big machine, yeah.
Yeah,
He has
at least 14.
Crazy.
When would they actually induce, like, or even just give the conscious sedation in the OR right before the case started, or would they do it in pre-op just before they wheel him in?
I can't remember, they were already sleepy when they
Most
went
of
in.
their patients
No, they
do
did it in the OR, I wanna say.
Most of their
Yeah.
patients do.
They Xanax them and then they put them
Yeah, I
on.
understand you did.
Oh, you want
Because
to
after
find
they
out
all
the
know,
patients.
This is like,
In the cath lab, we don't.
because anesthesiologist talks to them first, like they give birth, and then,
And then just put.
And here's a little one for
They
contracted with the like satellite MD offices, and they just give.
they have a binder of 200 optometrists.
Any other questions?
well, what else do we have on
Any other
that?
questions?
In their office,
Any
that's all
other
they
good
do
questions?
is
This
do
is
the
lunchtime. It is lunchtime.
So it's just like, it's like, no more questions, strictly like.
I think referrals, but they get
People there.
a financial kickback.
We thank you.
Thank you.
Yeah.
So
Thank you.
they-
Very nice.
Yay.
Good job. We appreciate it.